Thank you very much. The next presentation will be given by Professor Moratakova about a similar approach that with carbapenemase producing organisms, so that's one level higher in terms of resistance than the ESBL organisms. Just to understand you better, to explain to you.
Doing great. Welcome to this session. Well, actually, this is part of the series of this increment trial. This paper is just published today in Lancet Infectious Diseases, so the full paper is available as of today. The increment study, as Zaira was saying, was looking at the different aspects of resistant bacteria and treatment management procedures of infections caused by these resistant bacteria. And this part that I'm going to present you here is about the carbapenem-resistant enteric gram-negatives, which are causing a huge problem in the clinical setting. The main objective of this study is to compare the combination antimicrobials versus monotherapy in terms of mortality caused by these highly resistant bacteria. Well, Jesus Rodriguez Baño is the corresponding author. He's the president-elect of this society, but unfortunately, as Mario was saying, he's away, but he will be joining us at the end of this session. So if you have particular questions, he will be here for the interview. So just as ESBL producing bacteria, carbapenemase producing bacteria is a great danger in our clinical setting and causing a lot of problems. And infections caused by these bacteria usually carries a risk of mortality up to 40 to 60%, particularly if you think about the hematological malignancy and stem cell transplant patients. If the patients are colonized with these bacteria, consequently up to 50% of them can be infected, and after that the mortality rate could be as high as 60%. So far, most of the studies suggested a combination therapy with at least 2 antibiotics combined in vitro effective to treat these bacterial infections. But of course, when you combine these antibiotics, you increase the cost of the treatment, but at the same time, those antibiotics can cause significant side effects, particularly if you think colistin is the mainstream of the treatment for treating these bacteria. Colistin is highly toxic agent, particularly if it's combined with an aminoglycoside, for example. So as I said previously, the main objective was to compare mortality of combination therapy and monotherapy. And just as the ESBL study of increment trial previously presented, it's a multinational cohort, 26 hospitals, 10 countries. And we had 208 patients receiving monotherapy and 135 combination therapy. And as you see, the mortality rate was higher when compared with the combination therapy. But then, the main message from this study is that if you stratify your patients into 2 groups, one is in the low mortality score, and this score has been previously developed. There was a paper, again, from this increment trials in Mayo Clinic Proceedings in 2016. So you can stratify your patients, you can identify the low-risk patients and the high-risk patients, and I'm going to show you the criteria about stratifying the patients. So you see there is no difference between combination therapy and the monotherapy. But in those patients with high mortality score, then the combination therapy fares better. Well, we think that this is very important because this gives us the message that low-risk patients can be treated with monotherapy, and in that case they will be exposed less side effects, and that will be less costly, of course, to be treated with a single antibiotic. And of course that would also avoid overuse of antibiotics in this population, which might be a harbinger of emerging resistance. But high-risk patients should be treated with combination therapy, and also the mortality score is very useful to stratify these patients. Just for your information, this is the risk score for mortality used for these patient population. You see the reference there, you can see the details over there. So these 5 criteria, as shown here, This is the risk score previously developed, but obviously the last part was not used for this trial because the inappropriate therapy would not be suitable to be used because all these patients were accepted as treated appropriately. So this is the main message for this trial. Thank you very much.
Well, thank you, Murat, for your presentation. We will take questions at the end, as said before.